Okay, so this talk is a little different than our previous talk. So what I've tried to do, so I'm a clinical geneticist. I see children with genetic disorders in clinic, and I have sort of made this PowerPoint as if I'm talking to a parent in my clinic, trying to explain a particular condition that a child has. So it's going to be basic, and I hope that the questions that you have in your minds are answered at the basic level, like does everybody have TANGO2 gene? Do we have two copies? Those kind of things. So I will try to touch upon those questions that you might have. So human body is complex. It's made up of trillions of cells. So if you take one cell, and this is one cell, it has the blue area indicates nucleus that actually has our DNA in it. And then what is this DNA? It's all packaged in these 46 chromosomes. So they come in pairs. One comes from mother, one comes from father. And here, as you can see, as you go from top to bottom, you have these large chromosomes, and then you come down and you have chromosome 22, which, as you know that our children with TANGO2 have problems with chromosome 22. So this is chromosome 22. It's very small. And also you can appreciate that these chromosomes have dark areas and light areas. And the way we understand this is that the light areas are very gene rich. So they have a lot of genes on them. The darker areas are relatively gene poor. How many genes do we have? So scientists estimate that we have probably close to 20,000 genes, and they are all packaged on these chromosomes. All right? So we saw the picture of chromosomes. Where are the genes located on these chromosomes? So if you unravel this as a thread that is just coiled, and then you unravel this, and then you end up with this small structure we call gene. And talking about TANGO2 gene, this is a TANGO2 gene on chromosome 22. So how many genes can a chromosome have? Chromosomes can have many, many genes, hundreds. Sometimes larger the chromosome, more genes they have. And so the question is, do all of us have two copies of TANGO2? Absolutely, yes. So all of us have two copies of TANGO2 gene. And one is a maternal copy and the other is a paternal copy. So here is what TANGO2 gene, genes that are working well would be like this, one coming from mother, one coming from father. They're working well, there are no problems. And then we have a child who inherits one copy from mother and one copy from dad, and none of the TANGO2 copies are working well. And that's when the problem starts to happen. Okay? So both copies of TANGO2 gene need to be changed for a person to have TANGO2 disorder. Right? So that's basic. Everybody's born with TANGO2 genes. Most cases they work fine. And then here comes along a child who has problems starting from the beginning, and we find out that he has changes in both his copies of TANGO2. So that also brings me to another term which I want to introduce, that it's a recessive disorder. So recessive disorders are like that. Like you can have one normal copy and one copy that is not working, and you can have a very healthy life because you have at least one copy that is working well. But when none of your copies are working well, then you get the genetic condition. And this is called a recessive disorder. All right, so again, another way to demonstrate this, these are both TANGO2 copies working well, no problem. And here is a carrier, and this carrier is a parent like you. So you never knew that you had one copy that was not working well for TANGO2. There was no way for you to know, right? We all carry changes in our genome, and I could be carrier of something, but because maybe my partner is not a carrier, so I never had a child who had a problem. So genetics is complex. So a carrier can have a healthy life, no problem. And then here you have a child who actually does not have any working copy of TANGO2. And that child would have problems. So what are the chances of having a child with TANGO2 if both parents are carriers? So there is a 25% chance for parents to have another child with TANGO2 problem. And it's every time it's like the same chance. It's not like if you have 4 children and you expect 3 to be fine and 1 to have a problem. It's not like that. So every time there's a 25% risk. So what are the type of changes that affect TANGO2? And this is how I explain to my families in clinic. So if you take this book, which is our complete genome, this book has 20,000 pages, and that's the number of genes we have. So let's suppose that I have this TANGO2 page in front of you. So what are the changes that can happen on that page? A whole paragraph can be missing, half a page can be missing, and we call that deletion of part of the gene. And that's what we see very frequently. And that is from exon 3 to 9 deletion. And I'll show you what exons are, but this is part of TANGO2 that is deleted that we see frequently in European population. So that can be one change. And is this enough to cause problems with the gene? Of course, because the message is all altered now. This TANGO2 gene had a very important function. It was supposed to make sure your heart is working well, your brain is working well, your muscle is fine. And all of a sudden, you see this message that is just half of what it should be. Of course, there will be problems, right? But then, if you're a carrier and you have half a page missing, you're still going to be fine. The problem will be when both copies of TANGO2 have missing paragraph. And that will result in consequences. So here is a gene, and EX means exon, and this is TANGO2 gene. It has 9 exons. And exons are the most important part of a gene because they are trying to make a protein which has a role, like I said, it has a role in the development of the brain and the muscle. It has a very important role, this protein, TANGO2 protein. Now, all of a sudden you have a deletion, and guess what? The protein is not completely made because you have a deletion from exon 3 to exon 9, and the protein starts to be made, and it's like, oh, what happened? And it just disappears. So the protein is not there. So this is a common deletion we see in the European families. And even long before we knew about TANGO2, people knew about this deletion. People knew that some part of population carried this deletion and they were healthy. Nobody could tell that if 2 carriers would come together, they would have a child with problems. They didn't know that at that time. So this was from 2009, and it was estimated that that Europeans, if they looked at 1,300 Caucasians, then 3 of them actually had this deletion. So imagine that you're in a gathering and there are like just over 1,000 people, and at least 3 of them will be carriers, not having a full normal copy of TANGO2. Imagine it this way. So that's crazy, right? That's frequent. And then imagine that in that gathering, 2 people, they come together and they both are carriers and they decide to have a family. And then here you have a child who may be affected. So deletions, we know that they exist in our genome, but many times we have healthy lives, we don't have children with problems, and we don't even know that we carry them. What about our other families? So you must have seen on our Facebook group that we have a lot of families from Texas, a lot of Hispanic families. Like, do they have the same problem in TANGO2 gene as our European families? And actually, that they have a different kind of a change. So let's see what kind of a change they have. So here they can actually, so if you look at the page, their page is completely fine. There is no paragraph missing. But they have this small misspelling on that page, and that is enough to cause problem in that gene. So that is a change we see frequently in Hispanic population. So it's a change, we call it, and I'll show you the exact location on that page. Where G should be, it changes to A. So just that letter change from G to A changes the function of this TANGO2 gene. So here is the location. Here is the location where you see G, and this is, just a bunch of letters on that page for TANGO2. Imagine that big book with 20,000 pages, and we're just doing letter by letter read, and all of a sudden, in that child where G should be, it's now changed to A, and that is it. Can you imagine all those problems that our children go through is just because of this misspelling, and in both copies of TANGO2. So how common is that in the Latino population? So this is just estimates that we have from our tools that we use. So we have a large data set of healthy populations. So, and here you can see that there is data on Europeans and Latino and Africans, and you can see that in Latino, 22 individuals actually have this change. And this number is actually twice the number of people because it's looking at both the chromosomes. So again, it's frequent. And then and this plot here shows the ages of these people who are walking around being a carrier, not knowing that they are carriers. And they are everywhere from, less than 30 to 70 years of age, not knowing that they carry this change. All right, then are these the only two changes that we see in TANGO2 families? No. So we have this common Hispanic variant, we have the common deletion, which we see in our European families, and we have other less common changes that are spread out. So from our first 2016 paper, we had the red bar here, it shows the deletion. We had another family who actually had a smaller deletion. It was so we have instead of having exon 3 to 9 deletion, this family just had a smaller part of TANGO2 missing, and that was enough to cause problems in that family. And then there can be just a misspelling here and there. In this same year, Dr. Distel-Meyer's group published the study on their families with TANGO2, and they also had they found the deletion, which is the common one from exon 3 to 9, but they also had these small misspellings here and there. So genetics is complex. And so a mutation, a change can be benign, not cause problems in TANGO2, but a change can be really disease-causing. At least we know that these mutations that have been published, they cause problems. So then brings me to children with 22q11 deletion. Could they have TANGO2 disease? And we do have families in our community with 22q11 deletion, children with DiGeorge syndrome who actually also have TANGO2 disease. So how does that happen? So in DiGeorge, we know that it's a deletion. It's a missing piece on 22, also on 22. But so in that deletion syndrome, a number of genes are gone, like about 40 some genes are missing. The main gene in DiGeorge is TBX1, but TANGO2 is not too far from it. So those children actually have just deletion of TANGO2 along with all the other genes. Most children with DiGeorge don't have TANGO2, right? Because they have a second copy of TANGO2, which is working fine, right? So they would just have a diagnosis of DiGeorge, they have no problem. And again, going back to our original thing, both copies have to be changed in TANGO2 to have the TANGO2 disorder. So if that DiGeorge child has a second change on the other TANGO2 gene, then yes, that child will have both DiGeorge syndrome and problems related to TANGO2. So this is one example. This is a child with 22q11. He has very distinct facial features. We are usually able to recognize them by face. They have small hooded eyes. They can have small ears. They can have small mouth. They can have cleft palate, heart defect, immune problems. So their problems are very different, right? And we know that they have this 22q11 deletion. But what if this child also had a problem in the other copy? Then we would expect him to have more problems related to TANGO2, which would be rhabdo, like muscle breakdown, heart arrhythmia, metabolic crisis, which typically you don't see in DiGeorge syndrome patients. So clinically, if you have a child who has DiGeorge syndrome and he's coming back with very high level of CPK and metabolic crisis, then we should think of checking his second copy of TANGO2. He's already deleted for one, we know that because he has DiGeorge. But let's check the second copy, and if that is altered, then yes, he has a diagnosis of TANGO2 plus DiGeorge. And that change, the second change can be anything, right? It can be a misspelling, it can be a missing paragraph, it can be anything. So we know that the function of TANGO2 is disturbed, whatever that function is. And what is the function of TANGO2, right? We know that it's important for leading a good, healthy life, but what is the function? If we don't understand the function, then how can we treat this disorder in our children? We know that it has this fancy name of TANGO2, which actually is because it's in this family of proteins that are transport and Golgi organization. But what does that mean? What is it doing? And after my talk, Dr. Seema R will probably touch base on this more, but I wanted to introduce what Golgi is. So this is again a cell that I showed you. This is a very primitive version of a cell before, but this is a cell which has a nucleus. And it has many things in it, as you can imagine. It's very complex. It's a body in its own, right? It is doing everything. It's digesting, it's excreting, it's utilizing the nutrients, it is doing everything. And so there are parts in the cell that help it do everything. And one of these is Golgi. So what does Golgi do? So Golgi, mainly you can imagine it as a factory. Its main job is to process and package and send it out to any part of the cell. That is the main part of Golgi. And it's receiving proteins from what we call endoplasmic reticulum, which are these dots that you see around in these canalicular organelle. So it takes proteins, it packages it, sends it out. So that is if it's functioning normally. So just because TANGO2 belongs to that family in Golgi organization, is it doing anything to Golgi in our children? Is it not packaging the way it should? And there is not enough data for that. So in the first paper that we published, we looked at Golgi size in one patient cells, and we saw that the Golgi was reduced, but it's just one patient. We need to have more evidence that it's really doing something. We also found that in these spaces where the proteins are being made, and there is some evidence that there is increased stress in this part of the cell. But again, is the stress primary? Is it a secondary stress that you're seeing in these children? So there are so many questions that we have that are not answered right now. How do we connect the problems at the basic level of cell to our children who are actually in metabolic crisis? And so we know that there is a non-acute presentation of TANGO2, and then there is an acute presentation, right? So in non-acute presentation, we have children who have baseline cognitive problems, may have that muscle weakness, gait abnormality, difficulty with walking, speech, swallowing, and then head tilting episodes. These are non-emergent problems. Seizures, approximately 75% of children can have seizures. And hypothyroidism, Dr. Miyake said from talking to you, it looks like about 40% have thyroid problems. But then in emergency situation, these children are coming in either in coma or not able to walk and are passing red urine. They have elevated CK level when the normal level is up to 200 something. Their CK level is 200,000 or more because they have actual muscle breakdown going on. They can't walk. They may be in pain. How does the Golgi or other parts of the cell problems relate to all these problems that children have? We just don't have enough information to connect the two. And we know that these children are pushed to these crises with a viral illness or dehydration or not eating well, or we found some ketogenic diet because neurologists are trying to work on the seizures. Sometimes it can be difficult to treat, but we've seen at least few cases who've gone into crisis with that. And then in crisis, low sugar level, high lactate level. How does this connect to the cellular level, right? What is going on at the cell level? Because until we connect these two, what are we going to treat? How are we going to find treatment for this? And then, of course, life-threatening arrhythmia that is always that risk for these children. And then some of them get this AICD placed to prevent these arrhythmias. So it was in 2016 that Dr. Distelmeier's group and Baylor's group put together these families and published this. And this was just the beginning because there's so much more work that needs to be done. So many questions that remain to be studied. So, and I will just list, this is I think my last slide, list the questions that we want to answer. So how does TANGO2 work in healthy individuals, right? What is its main function? In children with TANGO2 disorder, what really happens at the cell level? In crisis, out of crisis? Like what is going on? Which part of cell is under stress at that time? And is Golgi complex clearly reduced in these children, affecting the normal function of Golgi? Is there a mitochondrial problem in these children? Is it a primary mitochondrial problem or a secondary problem that just happens because something is not working well? And why do these children get life-threatening episodes of muscle breakdown and cardiac arrhythmias? Why do they have hypoglycemia in stress? Could there be other metabolic pathways that could be playing a role? Why do children get seizures? What is the reason for the thyroid problems? And what starts the cascade of the metabolic crisis? Like, where can we stop it? What happens first? And how do we prevent these crises? So these are all the questions that we have, and this is just our beginning. We are just starting this journey. There is so much we need to cover, and just coming together like this is just one effort in trying to answer these questions. So thank you very much.